Hi, everyone. Welcome to the Concussion Discussions series brought to you by Integrated Brain Centers. I am your host, Amy Zellmer from Faces of TBI. And today I am here with Dr. Perry Maynard from Integrated Brain Centers. And we're going to be talking all about dizziness after brain injury. So welcome to the series.
Awesome. Thank you so much for having me. I'm excited.
Yeah. And, again, I think this topic is so important because, I'd say 90% of people who have a brain injury complain of dizziness in some capacity. And, I think one of the questions we'll cover today is what dizziness means to me might not be the same as what dizziness means to the next person, right?
Yeah, 100%. That's one of the things I cover, in the chapter is kind of how people describe it. One in a form that, that can help doctors a lot of times in kind of how someone describes it, but other times, I have so many patients where y'all even say something about their dizziness and they're like, well, no, it's not dizziness. It's this or it's that, there's a very specific way, and it can be. And that's why I think it's our job as the clinicians to help them learn how to describe it and bring it to life and to bring it into real words, whether it's like a lightheadedness or a bobbing or a disorientation or a fog, or a true spinning, or you might have individuals who say, I have vertigo, which technically means that they're spinning, but they're not really spinning. They're just foggy, but they think it's vertigo. So it can be a very difficult thing to describe. And unfortunately, a lot of times in traditional healthcare, they don't really dive that deep into it. They just kind of say, okay, or that doesn't sound like that's this because of the way they're describing it. But patients are confused. They don't know how to describe the sensation because it's a really awkward sensation to experience.
Let's talk about vertigo for just a minute, because that's a really great point. Vertigo is often used as like a blanket term for dizziness, kind of like migraine gets used as a blanket term for headache, when in fact, a migraine is a specific type of headache, just like vertigo is a specific type of dizziness. So why don't you talk to that point for a moment?
Definitely, yeah. So when you look at vertigo, by definition, what it really is either the person feels like they're rotating or the world is moving around them, which is very different than I feel lightheaded, or I feel lightheaded when I stand up, or I feel like I'm walking on, a boat. And the reason that's important because that actual spinning, true vertigo, a lot of times really is more inner ear, because if you look at, what is occurring when someone gets vertigo or feels like spinning is literally their eyes are moving and then they're quickly snapping back. Like I was kind of saying is when the eyes are, or when someone has true vertigo and they feel like they're spinning, that usually is the eyes are actually moving. And when those eyes actually move, so you have a slow phase where they drift and then a fast where they correct. During that slow phase, the world moves the opposite direction. And that's a lot of times what gives them the perception of either they're moving or the world's moving. And that is a inner ear mechanism. Now that could be coming from dysfunction in the actual inner ear itself or the part of the brain that regulates it. But that's, something like I'm kind of like lightheaded is far more non-descriptive. That could be blood sugar, that could be vascular, blood pressure, that still could be inner ear, but it makes it a lot more difficult versus a true vertigo. And the problem is when people label it as a true vertigo and doctors don't bother really looking into it, then they may say, well, cool, go to vestibular therapy because, it's an inner ear issue. And it's like, well, it really wasn't vertigo to begin with. It was something else. And maybe it was something in their neck. So those descriptions are really, really key, especially when it comes to dizziness. I always tell like young doctors or interns or things like that is like history and getting the details of what makes it better, what makes it worse, how long does it last. You should now know like 3 different things that it could be and figure it out right there, and that's the big thing with dizziness is the quicker you can figure it out, the quicker you can hopefully make an appropriate intervention and someone can feel better because when individuals go a long time with dizziness, it brings so much anxiety and secondary stress that it's really not cool to see people mismanage for a long period of time.
Yeah. Yeah. And you're talking about how the describing words that you use for dizziness. And when I was just recently in the hospital for something else, and they asked if I was feeling dizzy, and I'm like, well, things are not spinning, but I feel a little lightheaded. And it's like they're kind of like, what? Why? But it's like you said, they don't dig in. Like dizzy is it can mean so many things to so many people. So what are
Yeah,
some of
it's
the
a
ways
broad term.
that you will dig into that with a patient?
Definitely. So besides, like we mentioned earlier, of course, going into history and seeing how to come on, what provokes it, what makes it better. So besides that, that's really where some of the testing can come into play. So before we talk about the testing, if we think about dizziness, besides metabolic things or vascular things, all these kind of outliers, I'm going to leave those out of the discussion. More commonly than not, with concussions, dizziness is coming from one of three systems or a mix of all of them, either the inner ear itself, the neck, the eyes, or the parts of the brain that regulate and interpret all that information. So if we know that information, then we have to have tests that can test the inner ear, the neck, the eyes, and how well they integrate together. So one of the first things we do is we really assess balance. And we assess balance in different scenarios where maybe one's on a hard surface, eyes open, eyes closed. Maybe they're on foam, eyes open, eyes closed, head in different positions. So what we're doing is we're taxing those different sensory systems, so the inner ear, vision, and the neck, and we're seeing what does that do to balance, right? Because when one is dizzy, their balance most often is off. And when a person feels better from dizziness, their balance gets better, right? Because balance is really just a representation of you knowing where you are in the world.
Mm-hmm.
And dizziness is a problem where you don't know where you are really in the world. So balance can kind of give us a window to say, the inner ear is affecting their balance, or maybe they're not getting good information from their feet, or their neck is the reason they're not balancing well. So then we can dive a little bit deeper from there. And then we'll run different tests to look at eye movement. So we'll do what's called a VNG or a VOG. Same thing you'd see at like an ENT's office or an audiologist or something like that, where we can then further look and see, okay, when I put someone in dark, what do their eyes do? When I spin someone left and right, what do their eyes do? When I put someone in dark and I start tilting their head in different positions in gravity, what do their eyes do? Because all these systems are so intertwined, so we can start to say, the inner ear is giving you really crummy information, or your eyes aren't tracking well. Maybe this is more of a visual vertigo, or your neck is making your eyes do these funky things. This maybe is more of a cervicogenic dizziness. And then what we'll do a lot of times is, unlike a lot of exams where they want to just get a bunch of data to print on a paper to give to you and say, here's your problem or you're fine.
Right.
I don't care as much about that as my exam is to see, and so then we can make an intervention right there to say, this therapy will work. So if I have someone where, in the dark, they have, right, like an nystagmus, so their eyes are drifting and bouncing back. So they're getting the signals if they're moving when they're not moving. Well, I want to do things right then and there to stop that, because if I can stop that and then the person says, I feel better, even if they just say, I feel 30% better, or I feel better only for 5 minutes, I at least know I'm on the right mechanism and that therapy is going to be effective. Because that's the other problem too, is go to vestibular rehab. Everyone gets the same thing at vestibular rehab. Shake your head left and right, up and down, look at a strobe light, versus actually customizing it to why they're dizzy. Results are going to be so much quicker, and they're going to come with far less symptoms. People get so sick in traditional vestibular rehab, and I don't think it needs to be that way. Someone at the end of one therapy session, my goal is that they actually feel better, not that you're frying them out.
Mm-hmm.
So that's kind of wrong look at it, but then my treatment, or then treating what I find, further tells me that I'm on the right track. So it's kind of like, find what's wrong, make an intervention. Okay, that intervention now supports my thoughts. Okay, this treatment plan is going to be effective, versus just kind of guessing.
Mm-hmm. Yeah, and that's something I hear a lot in my group about, talking about vestibular therapy, if it's cookie cutter, it can actually make you feel really crappy. And I hear people all the time complain that, you know, I'm 6, 7, 10 sessions in and I just feel awful when I leave. And, you know, there's sort of the saying that like no pain, no gain. And people like, oh, you just have to push through it. And I'm like, no, like you should not be feeling legitimately miserable at the end of like 7 treatment sessions.
Yeah, no, if I had a patient that was at like the end of like 7 or 10 treatment and they were just like progressively getting worse or like throwing up every time, I would be like, what am I doing? I'm clearly not doing something right, or I'm not doing, I missed something. You know, there's certain conditions with the inner ear dizziness where sometimes you have to use certain techniques that have to do with like habituation, where you might induce a little bit of symptoms, but honestly, that's maybe a small percentage. A majority of the ones related to TBIs, there's a mismatch. And if you're doing the appropriate treatment, they should be getting better. You know, if, you know, do people get symptomatic in here? For sure. But if someone is like, even just like 2 visits in a row, they're not doing well, I stop and I'm like, we're doing something wrong. We're either pushing you too hard or using a wrong mechanism, because if you use the appropriate strategy at the appropriate rate, a majority of patients with dizziness should get better with each one, not worse. So yeah, I definitely, yeah, to get to 10 sessions and then still say, oh, we just got to push a little harder, is definitely something being missed.
Mm-hmm. Yeah. And I also have met a lot of people who have, you know, just gone the traditional route, seeing a neurologist, maybe seeing a dizzy balance specialist, and they're told that either they just have vertigo, BPPV, or that they have Meniere's.
Mhm.
And I'm like, I don't think that's it. Like for me, I was told I had BPPV, and they did the Epley
Mhm.
maneuver on me. It did nothing. Like it didn't even, doing the Epley should invoke the dizziness, because that's the
Mhm.
point. You want to find that
Yep.
dizziness and then move your head.
Yep.
It didn't even invoke dizziness. Like,
No.
and I had, I've told you this before, I had BPPV like 10 years prior to my brain injury. And that was like, if I tipped my head the wrong way, it was like the world just like spun out of control.
Uh-huh.
And so I knew that
True
that this
vertigo.
wasn't the same thing, but nobody would listen
Yep.
to me. I'm like, no, this is more like, and I literally kept telling people, I feel like it's my eyes. I feel like my eyes aren't working together. And they just kept
No.
insisting it was vertigo and doing the Epley maneuver on me.
No.
So I hope that
Yeah,
that story can resonate with someone watching and is like, okay, I need to find this guy.
yeah, and you're totally correct. You know, when you look at true, you know, BPPV, and there's so many different variants, and there's some that can be very difficult. But yeah, there's so many that I would agree. The common diagnoses are, yeah, Meniere's, BPPV, or the third one, which is PPPD or triple PD, which is just persistent perceptual postural dizziness, which is pretty much just a junk diagnosis
Yeah.
for. It's central. It's in your brain, and we just can't really find it. So
We
it's
don't know what to do
persistent.
for you.
Exactly. We don't know what to do, and that's where I think, you know, functional neurologists can really shine in identifying more of those central components. And I think where traditional fails is that everything to them is black or white. It's pathology or it's normal. But the problem is, for a majority of people, it's this gray area in between. You know, it's the subtleties. It's, I moved their head this way and their eyes started moving just for a split second. And most people would say, meh, that's normal. You see that in healthy people. But in our population, that can mean everything. And a lot of times that little error signal is enough to be causing their fatigue,
Mhm.
their nausea, their anxiety. Because really, when you think about dizziness, it's even more than dizziness, is that a lot of people come in not even describing dizziness, they come in describing fog,
Yeah.
anxiety, cognitive issues, or, you know, I got a patient right now where, you know, very overwhelmed in busy environments, having to do cognitive tasks, but there's a lot of subtle vestibular deficits. And a lot of times you fix those underlying mismatches, and then all of a sudden someone's brain turns on, because there wasn't a problem higher up. The problem was they didn't really know where they were at. And so that fog was their brain feeling lost or lost in the world. And then the symptom you describe is just a perception. It's how your brain is trying to make sense of what's going on in your reality. So, that's where I think the importance is. That gray area is that, no, you don't have a diseased inner ear. You're somewhere in here. And when you're somewhere in here, you're going to get missed a majority of the time because it's within normal limits.
Now, what about someone who feels like their eyes are moving? I know, like, I kept saying my eyes didn't feel like they were working together right, but I didn't feel like my eyes were shaking. When I would go to sleep at night, I did feel like my eyes were rolling around in my head. But I do hear people literally describe it that it feels like their eyes are shaking.
Yeah, definitely. So that can definitely happen. So like you said, if we're looking at eyes or abnormal eye movements, if your eyes aren't staying stable, they can really do one of two things. They can either slowly drift, and then your brain's like, whoop, come back to center, slowly drift. And that's where some people feel like my eyes are rolling in the head or they're drifting. Or you can get these little oscillations or these little shakes, which some will call, square wave jerks or different things like that. But really what that is people are getting this spontaneous activity where their eyes are stable, and then the brain all of a sudden shoots the eyes, and then the brain says, whoa, come back to center, And if you think about it that way, those people may experience brain fog or attention issues a lot of times because your visual system is what's helping you to attend to the world. And it's like a camera, and it's taking pictures of everything around you. So if your eyes are always oscillating, it's like taking a photographer and having them shake their hands every time they take a photo, it's going to create a blurred story or a blurred picture. So now your brain is trying to interpret that. So yeah, you can get those little shakes, and those are very common with concussions. And a lot of times that can cause people, like I said, fog, or a lot of times attention. People will have attention issues with that. And then if you can get their eyes stable, their attention becomes a lot better because now they can attend to the world, right? Attention is largely visually oriented, right?
Yep. And I would say too, the eye stuff, it made me feel dizzy. And then when you're constantly feeling dizzy, it's like, it's like your phone battery. It just goes, right? Like when you're dizzy. And when you're not dizzy, it can steadily decline. So yeah, for me, getting that dizziness cleared up was huge. It was a huge piece of my recovery, because once we got that dizziness, then the other stuff could get addressed.
Yeah. It's such a burden on people. I mean, like you said, it's, besides the symptom of dizziness, you see energy improve, you see memory improve, you see mood improve, people's anger gets better, because it's literally just like this nagging, annoying thing in the background that then they don't really know why. And then you clear it, and it's like people's brains just turn on. And it makes sense, because it's if you really think about hierarchy in the brain, if you don't really know where you are in the world, how are you to interact with it and then make a perception of it? The basis of making a perception of your world is off. So then the way you interact is going to be completely distorted. So, and that's where with every patient, if there's any little bit of subtleties there and cognitive deficits, we always start here, because half of the time clearing up this makes this better. But if I work on this and don't address this, a lot of times you run into walls.
Yeah. Well, this has been a great conversation, such an important topic. Like I said, I feel like the vast majority of us after brain injury struggle with some form of dizziness. And so thank you for being here and sharing your expertise today, Dr. Maynard. And anyone watching, they can find all your info below this video, or they can find you guys at integratedbraincenters.com. And they can find you on Instagram and Facebook at Integrated Brain Centers. And if someone would like more information about working with you, they can reach out and schedule a consultation, right?
Yep. So we offer free kind of 30-minute consultations, phone or in person. And it's really helpful because it allows us to see if an individual would be a good fit, or if we can guide them to the right practitioner. So it really, all it takes is someone's time in 30 minutes, and we can review your case and then decide what might be the best course of treatment for you. So, yep.
Awesome. Thanks for watching. I hope you enjoyed today's video. Be sure to hit that subscribe button so you don't miss any videos in this series. Like this video and head to Amazon to purchase Concussion Discussions.